Hello, everyone, and welcome to the New Jersey Department of Health Hepatitis C Surveillance Case Definition and Investigation webinar. Today is Tuesday, November 14th, 2017. I'm very pleased to have Ms. Bernice Carr, who is the New Jersey Department of Health Hepatitis C epidemiologist, present today about all of the new case definitions and case classifications and our new Hep C guidance with the disease investigation. So you're in for a real treat with a lot of information. We've posted the slides as well as the guidance for you to follow along. So just a few housekeeping items to go over. Today's webinar is being recorded and archived. It will be posted on the New Jersey Department of Health website where you can view it at a later date. This webinar does confer 1.5 public health and nursing credits for those who are registered. Please note that if you're viewing this webinar in the archived and taped version, there are no credits available for people who watch it in the not live situation. So you are in listen only mode. So we encourage you to put your questions in the question box. You can see it should be on the right side of your screen. We'll be looking at questions and addressing some of the questions that we receive after Bernice's presentation. We've also included the handouts, so you may follow along with the slides and take notes. After the webinar, you'll receive a link to the evaluation. Those seeking continuing education credits must complete the evaluation. You must complete the evaluation in 5 days. After the evaluation closes, we will be emailing you your certificate. So without any further ado, I'd like to introduce Bernice Carr, who will be our presenter today. As I mentioned earlier, Bernice is our new hepatitis C epidemiologist. She is responsible for working on the surveillance with hepatitis C, and she's going to share a lot of the new case definition and the new guidance information with you. So Bernice, take it away.
Hey, good morning. Thanks very much, Laura Taylor, for the introduction. Welcome again to the webinar on hepatitis C, surveillance disease investigation and case definitions. As Laura said, I am the epidemiologist who is working on hepatitis C surveillance. So with this, let us delve into hepatitis C. We have quite a bit to cover today. First off, the objectives of this webinar are fourfold. We will discuss surveillance of hepatitis C, which I will refer to thereon as HCV. We will introduce New Jersey Department of Health Hepatitis C case investigation guidelines. We will articulate the use of the 2016 standard case definitions and the 2017 proposed perinatal case definition. And finally, we will discuss examples and tips for HCV investigation. So first, just a few facts about hepatitis C. Many of you are probably aware or knowledgeable about those. HCV is a blood-borne virus which causes liver infection. It has an incubation period of 14 to 180 days with an average of 45 days. Most new infections occur by sharing needles or equipment used to inject drugs. However, there are other means of transmission. Some are healthcare associated, example through dialysis or through needle stick injury. And children born to infected mothers are also, this is also a means of transmission. We know that 70 to 85% of newly acquired HCV infection are asymptomatic, which means 15 to 20% will have symptoms. And most end up being a long-term or chronic disease. So majority are not aware since most are asymptomatic. There's no vaccine for HCV, but there are effective treatments. So why do we do surveillance? And we do surveillance to define the burden of hepatitis C in New Jersey, to identify trends, to identify HCV outbreaks, to identify new risk factors for transmission, to develop targeted educational message and about HCV, and to inform people at risk to get tested. We also want to work to get patients into treatment and to get cured. So I must point out that at NJDOH, we are striving to improve on HCV surveillance. So next, we'll talking about treatment, just a few facts about treatment. Some may not be aware that treatment is available, and the primary goal of treatment is to reduce or eradicate HCV viral load, thereby reducing all-cause mortality and liver-related health adverse consequences, including end-stage liver disease and hepatocellular carcinoma. The first direct-acting antivirus was approved in 2011. However, over the years, there have been advances in these treatments. They offer simpler dosing, fewer side effects, shorter treatment duration, and higher cure rates. We know that these treatments can cure up to 90% of individuals who adhere, and it's important to stress on the fact that adherence is key to success. Successful treatment results in sustained virologic response, and this is defined as the continued absence of detectable HCV RNA for at least 12 weeks after completion of therapy. The therapy options vary by genotype. And the link at the bottom of the slide provides detailed information to include facts on currently approved treatments. So whenever you get a chance, feel free to peruse through this link. Now, the Communicable Disease Reporting and Surveillance System, CDRSS, is the main tool used to capture and report details of a positive hepatitis C case. Some participants on this webinar do have access to CDRSS and use it on a regular basis. Please note, though, that we are in the process of a CDRSS redesign, and so this interface will look a bit different in the redesign scheduled to be rolled out in 2018. At this point, let me take the opportunity to introduce you to NJDOH new HCV investigation guideline. The rest of the presentation will focus on our new guide and investigation processes. The New Jersey Department of Health recognizes that being a high-volume disease, HCV case report investigation can overburden the limited resources available at the local health departments. This guideline aims to provide the process for investigating and classifying cases reported with HCV, with a focus on the identification of instances in which limited resources are most likely to have a positive public health impact. It provides HCV acute and chronic case definitions, as well as the new proposed perinatal case definition. It provides details on the local health department investigation responsibility. It discusses HCV serology as well as test names. It's important to note also that in here is details on how to address healthcare and correctional facility cases. Finally, in the appendix, one will find the revised CDS-17 case investigation form, a standard non-perinatal case classification algorithm, an HCV template letter, a perinatal case classification algorithm, and interpretation of HCV laboratory test names used in CDRSS. Now, based on the Centers for Disease Control and Prevention, CDC's recommendation, and as well as grant requirements, we in New Jersey have incorporated questions geared at both acute and chronic cases. And those listed on this slide are the risk factors that represent those that we are most interested in. So has the patient ever have contact with a person known to have HCV? Did the patient ever inject drugs not prescribed by a doctor? Did the patient ever receive a blood transfusion before 1992? Did the patient ever, was the patient ever exposed to someone else's blood, for example, a medical worker? Did the patient undergo hemodialysis, and was the patient ever incarcerated? All of these risk factors, as well as a few more, are now listed on the new CDS-17 form, which is in the case investigation guideline. Now, in terms of the priority populations for investigation, most importantly, at NJDOH, we are interested in suspected acute HCV cases, and these are irrespective of age. So it doesn't matter what age. Once they are suspected to be acute, we would like to have these cases fully investigated. Cases are acute for the first 6 months of infection. Now, the rationale for prioritizing acute cases is to promote risk reduction, reinfection, and to provide cases with counseling and to link cases to care. Secondly, individuals who are less than 30 years of age and greater than 70 years of age are also the priority population. Please know that this population currently represents only about 25% of Hep C cases reported in New Jersey. This population is most likely at risk to be acute, and those over 70 years of age includes baby boomers and their possibly healthcare associated infections exist in this population. Now, the other group we are interested in are perinatal. And these are children who are less than 36 months old, born to an infected mother. And why perinatal? And that's because these cases, they can be monitored and provided care as soon as possible. Finally, we are interested in individuals who are patients of a healthcare setting. For example, at hemodialysis. Investigations of these single cases is a very important public health response as it can result in the identification of an outbreak or unsafe clinical practices that are putting additional patients at risk. Now, this slide highlights the surveillance HCV data collected by county in New Jersey for acute or newly infected cases in 2016. It shows that Burlington, Gloucester, and Hunterdon were the 3 counties with the highest crude rate of acute cases. Due to the high burden of HCV in New Jersey, we are hoping to hone in on why we observe such trends. Is it related to surveillance? Is it related to laboratory and clinical reporting? Or some other underlying cause? In contrast, on this slide, we see the data for the same year for chronic cases, indicating that Cumberland, Cape May, and Camden had the highest rate of reported cases. Again, we hope to hone in on the underlying reason for this trend. Data from one study in the south of New Jersey suggested that the relatively huge population of baby boomers and those who are likely to get tested could be a major factor driving these numbers. Now, in terms of hepatitis C surveillance in New Jersey, the local health department responsibility summarized in this graphic. So first, a positive HCV laboratory test is reported in CDRSS, or it could be reported directly to the local health department, and this triggers an investigation. The expectation is that the local health department would investigate the case to collect sufficient information needed to diagnose the case as acute or chronic or perinatal, as well as to accurately report demographic information and the case's risk factors. The local health department is expected to ensure or confirm that the case is educated on methods to prevent transmission of HCV, and where possible, provide information related to linkage to care. The revised CDS-17 investigation form, as mentioned before, is provided to help in investigation. Now, the following table lists the most common HCV-related laboratory tests used to screen or diagnose HCV, and these are listed in CDRSS laboratory test name dropdown. The column on the right matches the test name by type of test, and on the left, the specific names are listed. So hepatitis C virus antibody, hepatitis C signal to cutoff, hepatitis C genotype, hepatitis C qualitative or quantitative, alanine aminotransferase ALT, alkaline phosphatase ALK-PHOS, aspartate aminotransferase AST, and bilirubin. So in terms of laboratory tests, the initial test for diagnosis and screening of HCV infection uses serologic assays that detect human antibodies generated as a response to HCV infections. There are currently 3 approved assays for this test. So there's the EIA, the CIA, and point of care rapid immunoassay. So a positive antibody test indicates that HCV infection occurred at some point in time. However, it does not differentiate whether the person has resolved or current HCV infection. Investigators in New Jersey are currently using HCV signal to cutoff and not HCV antibody reactive or positive in case classification. However, moving forward, we will not be differentiating between reactive or qualitative antibody and signal to cutoff. All positive antibody results are reportable to New Jersey, and as well as all seroconversions. So that is any case who had a documented negative antibody for HCV followed by a positive antibody or RNA test. This is reportable to NJDOH. Now, the confirmatory or supplemental test for HCV is hepatitis C nucleic acid test NAT, which is usually detected within 1 to 2 weeks after initial exposure. And there are 2 types of NAT. There's the hep C RNA qualitative, which provides a yes or no answer, or detected or not detected. And there's the hepatitis C RNA PCR quantitative test, which provides a numerical value in international units per milliliter. And this is usually used for baseline level or to monitor response to therapy. And finally, there's the hepatitis C RNA genotype, which uses a test kit assay with a specific minimum viral load for detection. It's important to note that there are genotypes 1 through 6, and these genotypes have various subtypes, usually A or B. Now, this slide presents 2 charts. On the left, it illustrates the pattern which is likely after a person is newly infected with HCV. On the right, there is an illustration of the pattern in a chronically infected person. The yellow line represents anti-HCV trajectory, whereas the black line represents ALT trajectory. The red bar highlights HCV RNA, and the green bar highlights symptoms. So let us start by focusing on the left. So what happens in a recent infection of HCV? ALT increases sharply, and it may be elevated to 200 international units per liter or more. Since most people do not have symptoms, a few may have symptoms, but since most do not have symptoms, they are often not identified and diagnosed with acute HCV. If symptoms does occur, however, it is usually 6 to 7 weeks after exposure, ranging from 2 to 26 weeks, and persists during the time when enzyme levels are elevated. So which is what we see here, elevated ALT and symptoms. About 40% of persons infected will have detectable antibody to HCV in their serum approximately 10 to 11 weeks after exposure, with an increase to 80% by 15 weeks. Conversely, all infected persons will present with antibodies 6 months after exposure and remain positive generally for life. So this is what is happening here. HCV RNA NATs can be detected as early as 1 to 2 weeks, so very early here, after exposure. Now, for those who resolve infection, the ALT returns to normal and RNA disappears. So that's over here, as the anti-HCV rises. Therefore, this proves that antibody test alone is not able to distinguish between recently infected or resolved infection. On the right is the usual pattern for chronic infection, which is characterized by persistent RNA. So we see that all throughout, the person will have HCV RNA in their serum. However, the ALT levels may fluctuate. This fluctuating ALT indicates continual liver inflammation. In chronic HCV infection, ALT generally tends to be lower than for recently infected. Again, notice the similarity between the anti-HCV trajectory for chronic and for acute. So, which points to the fact that one cannot use anti-HCV antibody to distinguish whether a person is recently infected, whether the person is chronic, or whether the person has a resolved infection. So now this chart here highlights the CDC's recommended testing sequence for identifying current HCV infection. So it usually begins with the HCV antibody screening test. If this test comes back non-reactive, it means there's no HCV antibody detected, so you stop testing. However, if the testing there should be a follow-up test within 6 months. On the other hand, if the person has HCV antibody detected in their serum, it could mean that the person has, as we mentioned before, current, past, or resolved infection, or it could be a false positive. But what needs to be done is, if once this is reactive, the person needs to have an HCV RNA test. If this HCV RNA test is not detected or it's negative, it means the person does not have current HCV infection. And however, if the person is susceptible or has exposure within 6 months, they should be follow-up for testing. If the person has positive HCV RNA or it was detected, it means the person does have current HCV infection, and the person should be linked to care if possible, as much as possible. Now, in terms of linking patients to care, it is important to distinguish people with chronic infection from those whose infection has been resolved. So on this slide, I'm just going to highlight the supported labs, which are the liver function tests, and they are usually reported when a positive antibody is reported. And so first we'll start with the ALT. An ALT is a protein, it's only made by the liver. And it goes into the bloodstream when the liver cells are damaged. And this is possible from HCV infection. AST, likewise, is a protein made by the liver cells. When liver cells are damaged, AST leaks out into the bloodstream, and the level of AST in the bloodstream becomes higher than normal. AST levels, however, is not as helpful as the ALT level for checking the liver, and we will see this later in the case definition. Bilirubin is a yellowish substance that is created by breakdown of hemoglobin, and bili is released from destroyed red blood cells and passed on to the liver. If the liver is not functioning properly, which could indicate HCV infection, bilirubin will not be properly excreted. Therefore, a higher bilirubin level may mean that the liver is not functioning properly. Bili levels greater than 2.5 milligrams per deciliter may suggest that the patient presented with jaundice. Of even less importance is the alk phos level, but it is usually reported. It does not necessarily reflect liver damage or inflammation, but rather a blockage of flow in the biliary tract or a buildup of pressure in the liver. Many with HCV will have normal alk phos. Okay, so now let's talk about the revised case definition. And the Council of State and Territorial Epidemiologists, the CSTE, proposed these new case definitions for acute and chronic in 2016, and they were accepted by the CDC. However, the perinatal was proposed in 2017, and it is expected to be accepted by CDC soon. But for the chronic and acute, although these definitions have been partially applied in the last year, we expect to fully implement them in 2018. Of note, what's really different in this case classification, what will be different moving forward compared to what we've been doing is there'll be a new probable classification. Likewise, all positive, that means all reactive anti-HCV, irrespective of signal to cutoff, will be reported and be used to classify a case. So first, let us look at acute HCV. And so in terms of the clinical criteria, it's an illness with discrete onset of any sign or symptom consistent with acute viral hepatitis. So that could include fever, vomiting, nausea, diarrhea, abdominal pain, and jaundice. So symptoms and jaundice, or symptoms and a peak ALT level which is greater than 200 international units per liter. Now, in terms of the laboratory criteria for acute diagnosis, the patient needs to have, or the case needs to have, a positive test for antibodies or the anti-HCV, or they should have NAT detected, so it should be detected or positive, or HCV viral antigen, and that is when it's available or approved. Now, in terms of classification, so as I mentioned earlier, there'll be probable, so this confirmed or probable. But first, for confirmed, an acute confirmed case meets the clinical case definition and has a positive HCV detection test, NAT test, or the case had a documented negative HCV antibody, HCV antigen, or NAT lab test results followed within 12 months by a positive result of any of those, regardless, not really any of those, but positive result of NAT or HCV antigen, regardless of signs and symptoms. So two criteria, just to reiterate, the case should have positive NAT to be an acute confirmed, or the case would be a seroconversion case. Now for acute probable, the case is acute probable if the case meets the clinical case definition and has a positive anti-HCV test, but the case does not have positive or detective HCV NAT or antigen, and the case does not have a seroconversion. Now let's talk about chronic. So the definition for chronic HCV clinical criteria is as such. So the case has no available evidence of clinical and relevant lab information indicative of acute infection. Note that most HCV infected persons are asymptomatic. However, many have chronic liver disease, which can range from mild to severe. In terms of the laboratory criteria for diagnosis, the case should have positive HCV or detected NAT test or via HCV antigen. So in terms of chronic confirmed, the case does not meet the clinical criteria or has no report of clinical criteria, and the case does not have a seroconversion, which is a documented negative HCV antibody followed within 12 months of a positive result. And however, the case has a positive NAT test or antigen test. So again, you need to have a positive HCV NAT to be a confirmed case. The chronic probable case, the case does not meet the clinical criteria, same as confirmed, and the case does not have a seroconversion, and neither does the case have a positive NAT test, but the case has a positive HCV antibody. Now, I know this it's a lot of words, but we're going to there'll be a table provided later on which will help to make this much easier to understand. Okay, now in terms of the local health department investigation priority. So let's talk first about cases less than 30, greater than 70 years of age, which are one of the main population of concern. Now, this is discussed in great detail in the hepatitis C investigation guideline documents. On this slide, we are only highlighting the main points. So the local health department should make 2 attempts for information from the provider who ordered the test. 2 attempts should be made to the patient directly if information from the provider was not received. A final letter should be sent to the patient if neither provider or patient can be reached. Please enter all information in CDRSS to include risk factors and treatment. Use Appendix B, which is the HCV case classification algorithm for classification and closing of cases. If there is no response to any of the attempts within 30 days of sending the letter, indicate in CDRSS under case comments and close per algorithm. Now this slide here shows a template of the letter which should be sent to patients after there's no response. And it's also in the investigation guidelines, so you could make a copy of it. Now, in terms of the local health department investigation responsibility for cases between 31 and 69 years of age, the points are summarized here, and it's also described in great detail in the case investigation guideline. And one of the main reasons we ask to have investigation of this population is because we really want to identify acute cases. And as mentioned before at NJDOH, we are trying to improve our surveillance efforts. And so it's important to try to identify as much cases, acute cases as possible. So the local health department or the investigator should make a single attempt to collect information from the provider who ordered the test for any case who falls within this population. All information should be entered in CDRSS as discussed before to include risk factors and treatment. Use Appendix B to assist in classification and closing of the case. And if no response, please indicate in CDRSS on the case comments and close per the algorithm. Now, this slide shows the newly revised CDS 17 form, which was mentioned earlier in the presentation. And it's also presented in the case investigation guideline document as Appendix A. And I should add that it's now in a downloadable format and fillable format on the website. And these links at the bottom of the slide can be accessed to get this form. So I'm going to talk about this form a little bit more, and so it's broken down. First, we will look at the top portion. patient information, and diagnosis. So as discussed before, we really want to improve on surveillance efforts. And so we want to make a better effort at retrieving information such as ethnicity and race. And so it's very important to look at this investigation form and try to capture this information, as well as diagnosis. Was the patient diagnosed before? And if so, what was the date of diagnosis? And the second part of this form lists clinical symptoms and laboratory information. And I must add that this section is particularly important to identify acute HCV cases. So it asks for symptoms. Did the patient have symptoms? What was the onset date of symptoms? And as well as what was the reason for testing? Did the patient have a negative antibody test within 12 months, which is, as we saw in the case definition, is a confirmed acute case. And on the right, there's a spot for listing all HCV-related tests. On this slide, the risk factor section is highlighted on the form. And we really want to increase or improve our efforts at retrieving this information as much as possible. And so I mentioned most of these risk factors before. And so it's important to know, did they have these risk factors or no, or if it's just unknown. And we would like to have those reported in CDRSS. Now we're going to look at some HCV case closeout scenarios in CDRSS. How do we interpret test results? We look at the new algorithm, and we'll also look at serology examples. So this here is the standard HCV algorithm, and it's Appendix B in the investigation guidelines. So if you have a copy of the guideline, you could take a look at it right now. And if you notice here, there's a blue horizontal line which separates two sections of the algorithm. So below the blue line is where the investigator will place most of his or her focus on. And above the blue line describes how or illustrates how NJDOH plans to manage newly reported electronically reported HCV testing results. So bearing in mind that the burden of HCV in New Jersey is high and that the resources for investigation at the local health department level are limited, we decided to design this method to aid in classification of electronic cases in particular. This would be very important as we move forward in fully implementing the 2016 CSTE case definition, as we expect an increase in the number of cases due to the acceptance of all positive antibody tests, reactive or signal to cutoff. So let us focus on the top portion of the algorithm. So just a little walkthrough. So cases reported in CDR will be reported in CDRSS with a HCV antibody test, qualitative or quantitative, as the only test that a person has. And this case will be closed as probable closed. If another test is added to a case with a previous antibody test result, the case will be changed to RUI pending for local health department investigation. Additionally, New Jersey Department of Health will conduct routine analysis on all probable closed cases to look for elevated liver enzymes, in particular the ALT, and to also look for cases associated with a healthcare facility. Cases for which either of these are found will be changed to report status pending, and the local health department will need to further investigate using the protocols defined earlier. So the possible scenarios are as such. So there are 4 possible scenarios. So first, the HCV antibody positive test is only reported in CDRSS. This case will be closed as probably closed. If the case has the HCV antibody positive reported, plus we found that the ALT is over 200, the case status will be changed to RUI pending, and local health department investigation will be warranted. Likewise, it's the same for if the case is found to have a healthcare associated risk. The fourth scenario, the case has a HCV antibody positive only, and then this laboratory result is followed by an HCV not positive. The case status will be changed to RUI pending, and the local health department will need to investigate. So this from the RUI pending, it pretty much follows into this lower portion of the algorithm, and this is where the local health department will place most of his or her focus on. And we are also aware that some cases are created manually, and so we ask that the local health department refer to the investigation priority to assist in investigation. So let us look at the left part of the algorithm, which speaks to the presence of HCV not positive reported in CDRSS. So there are 2 scenarios, and we're following from the previous ones. So scenario 6, the case has positive NAT. However, the case does not have reported HCV-related symptoms and jaundice or ALT greater than 200 IU per liter. Neither does the case have a seroconversion. This case will be closed as subtype chronic, case status confirmed, report status LHD closed. In scenario 7, the case has reported HCV-related symptoms and jaundice or ALT, or the case has a documented seroconversion. The case will be closed as subtype acute, case status confirmed, report status LHD closed. So now we're going to look here at the middle portion of the algorithm, and what does it really mean? So we're looking at the situation where the case has a positive antibody test reported, and in scenario 8, the case does not have a test conversion. However, the case has reported HCV-related symptoms and jaundice or ALT greater than 200. The case will be closed as subtype acute, case status probable, report status LHD closed. In scenario 9, just following, the HCV antibody test is positive. However, the case does not have a test conversion. Neither does the case have related symptoms and jaundice or ALT greater than 200 IU per liter. That's on the very right side of this section. Then the case status will be closed as subtype chronic, case status probable, report status LHD closed. So finally, let's look at the right side of the algorithm, and what does it mean? So the case has a positive antibody. Now there are 2 scenarios again. In scenario 10, the case has a test conversion, and the case has HCV RNA not test done, which is positive. Then this case will be closed as acute. That's subtype acute, case status confirmed, report status LHD closed. Scenario 11. That's on the right, the very right side of this part of the algorithm. The case again has a positive HCV antibody. The case has a test conversion. Now, this case has a reported NHC which is negative or not detected. Then the case is closed as subtype pending. Case status, not a case. Report status, LHD closed. And we ask that for any other situation that NJDOH will be contacted for case classification. Now, many of you who perform these investigations or use CDRSS, you may have dealt with this rare circumstance where genotype insufficient virus or sample is reported. And there are two examples we can look at for this situation. So example 1, the case has a positive antibody plus this test reported for genotype as insufficient as the only test reported for this case. The case should be closed out as subtype chronic, case status probable, report status LHD closed. In the second example, if genotype test insufficient virus or sample is reported as the only test for this case, the case should be closed out as pending, case status not a case, report status LHD closed. Okay, so we spoke about treatment before. We'll be providing some facts, but I just want to talk about how do we handle treatments in CDRSS. Now, all persons identified with HCV active infection, that is, they have positive HCV RNA, should be referred to a medical provider who can further evaluate and manage this individual's HCV infection. And having this information is in CDRSS is another important effort of NJDOH in improving HCV surveillance in New Jersey. So, if therapy information is collected for a case, please select in CDRSS on the Clinical Status tab, Treatment Selection, and go to Add New Treatment. Click on Treatment dropdown and select the specific treatment that the person is receiving or has received. Please add any other information related to linkage to care in the comments section on the treatment. All right, so let's talk about perinatal HCV, and this refers to children or infants who are 36 months old or less. So as was mentioned earlier briefly, the CSCE has proposed in 2017 a definition for perinatal Hep C, which will most likely be accepted by CDC by the end of the year. So it means this definition is subject to minor changes. However, we do not, it's not necessarily, there may not necessarily be any change. So the definition is as such: clinical criteria. Diagnosis of HCV infection in an infant between 2 months and 36 months of age, or diagnosis of HCV infection in a pregnant woman. Laboratory criteria for diagnosis: HCV RNA not positive, so that is the quantitative or genotype for infants 36 months of age and under, or HCV antibody positive and no or unknown HCV RNA NAT for infants who are 18 to 36 months of age. So the infant should be 18 months of age to have this test accepted. Please note that all perinatal hepatitis C cases should be reported by date of diagnosis for the infants. And also note that infants 36 months of age and under should only be assessed for perinatal HCV infection and not according to the 2016 CSTE case definition for hepatitis C. That's the standard case definition. So now we have provided a perinatal HCV algorithm to assist in classifying the case. So this algorithm, for the most part, summarizes what I mentioned earlier in terms of the case definition. So an infant is found to have positive HCV NAT, and the infant is between 2 months and 36 months of age. This case should be closed as Hep C perinatal, case status confirmed, LHD closed. If a HCV NAT test was done on the infant, but that test came back as negative or not detected, the case should be closed as perinatal Hep C, not a case. If the case is less than 36 months of age and HCV NAT test was done, was not done, or it's unknown if the test was done, but the case has a positive antibody test reported, the case status should be changed to perinatal Hep C, RUI pending, and this case should be held open for receipt of HCV NAT test. Now, following the receipt of this test, if it's positive, it's going to be closed as earlier as Hep C perinatal confirmed, and if negative, it will be closed as perinatal not a case. Please note that we ask that all the mother's information should be added on the contact tracing in CDRSS. Okay, now the following is a table that we put together to make the investigators' life a little bit easier for classifying cases. So you could take a moment to browse through it and make some sense of it. Okay. So as you notice, I'll just do a quick overview of this table. It lists on the left the disease subgroups. So the three there, well, it could be chronic, acute, perinatal, or pending. So these are the subgroups, or the case, subgroup, and the case status could be confirmed, probable, or not a case. And then the rest of the table lists by symptoms or positive NATs, HCV antibody, and based on the presence of those, you will determine whether what case status and subgroup that case should be. All right, so we're nearing the end of our presentation. We're going to talk about special facilities, and these are dialysis and correctional facilities, which we do get quite a bit of. So first, let's talk about dialysis. Now, so dialysis patients, they are at high risk for infection for a number of reasons. They are exposed to prolonged periods of vascular access. There is a lot of opportunity for person-to-person transmission of agents. Most times, these patients are immunosuppressed, and many of these patients require frequent hospitalizations and surgery. Now, to reduce transmission of infectious agents, dialysis centers in New Jersey are required by law to routinely test patients. And these facilities are proactive about reporting seroconversion and working with public health officials to determine where breaches may have occurred. So just a little tidbit about how dialysis patients are handled in New Jersey. So it's recommended that dialysis patients should be tested upon admission to the dialysis facility for ALTs and anti-HCV. If negative, they should be tested monthly for ALTs and every 6 months for anti-HCV. If there's a noticeable spike or rise in ALTs, it's recommended that anti-HCV testing be done. But please note, a rise or ALT spike is never defined. If a person tests positive for anti-HCV, we always want the facility to follow up with HCV RNA testing. If seroconversion occurs, we recommend prospective surveillance on negative anti-HCV monthly for 6 months, then another anti-HCV test 6 months later. So facilities generally have patients on a schedule. Most test the HCV negative patient population every January and July. We sometimes get facilities admit a patient in May and then not test again until January. We would recommend testing in July to get them on the facility schedule to avoid going for more than 6 months without testing. Please note that these recommendations are based on the CDC guidance document, and you can reference the link at the bottom of this slide for a more in-depth explanation. So in terms of CDRSS, we ask that if a case is a current or past recipient of dialysis, you document in CDRSS as follows. You go to the clinical status tab, select treatment selection, then patient classification, and select long-term dialysis. Also indicate on the risk factors, the risk factor tab, that the person is undergoing long-term dialysis. The LHD, the local health department, should contact NJDOH for all seroconversions. So that's important. Please contact us for all seroconversions to determine if a thorough investigation is necessary for a HCV-infected dialysis patient. Okay. So for correctional facilities, please note that state institutions are required to report all positive HCV results by law directly to NJDOH. Some state institutions have been trained to use CDRSS within the recent months, and NJDOH will continue to work to streamline case surveillance and CDRSS reporting with the state institutions. We ask that the local health department assign all new state institution cases report status LHD review, and this is because the state institutions will be providing, or they are expected to provide information on this case in CDRSS. It's also noted that correctional facilities have procedures in place to notify the local health departments when a prisoner is released into their jurisdiction with any communicable disease, and that includes HCV. So when a case is released into jurisdiction, the local health department should investigate this case as necessary. What's very important to note is that the local health department is responsible for investigating all non-state correctional facilities. So now I will talk about some tips and some things to be aware of in terms of reporting to CDRSS and working with cases in CDRSS. So please be aware that you do not need to merge acute HCV cases with other subgroups. So any old acute HCV cases, and that is cases which were created more than 12 months prior. So for instance, if a person has an acute HCV case created in 2015, and then that person has a new HCV case created in 2017, please do not merge the new pending case with the old acute case. Rather, create a new chronic case for this person. Likewise, on the other hand, please do merge a pending subgroup if the person was created within 12 months of each other. For further information on merging cases, please reference the CDRSS frequently asked PDF link, which is provided on this slide and as well in the guidance document on page 4. Finally, we want to mention that there is no need to update or contact or any laboratory information for cases which were DHSS approved and are chronic confirmed. So this slide provides resources on testing, screening, lab tests. They're very useful, so feel free to look them up. At this point, I would like to say thank you for your participation in today's webinar. And I would also like to take this time to acknowledge and thank the management and HCV team members here at New Jersey Department of Health for their tremendous support and assistance in putting the guidelines document together, and as well as reviewing and editing this webinar. So I'll just make mention of specifically Lisa McHugh, Rebecca Greeley, Dr. Ed Lifshitz, Laura Taylor, Jason Mayer, and I have to introduce you to the new member of our HCV surveillance and prevention team, Nurse Mary Ellen Wiggins. I also want to thank the technical team at NJDOH. Thank you very much, and we will open the floor for any questions.
Great. Thank you, Bernice. That was wonderful. Very informative. A lot of information.
A lot of information, and we know it might be a bit overwhelming, but we'll get there.
And again, I want to point your attention to the guidance document, which really has a lot of clarity and assistance with classifying cases, helping with case definitions, and Bernice mentioned twice, there's that Appendix E, which is a great chart for you to print out and use as you're classifying your cases. But, Bernice, we have a couple questions here. How about we take a few minutes and let's answer them. So one question is, why are we handling cases of 30 to 70-year-olds differently than those who are less than 30 or over 70?
Yes, okay, that's a good question. So first, we recognize that the burden of hepatitis C in New Jersey is huge. It's a lot. And we also know that the resources at the local health department is limited. And finally, but not least, we based on our previous surveillance, we are aware that many of the cases who are less than 30 years of age and over 70 years of age are at greater risk for acute hepatitis C infection. And so we really want to place more of our focus on that group. And this group only represents 25% of cases reported in hepatitis C. So we also hope that we are also helping the local health department as well.
Great. So another question is, so when should we start to implement this new case definition? When does all this start?
Okay, so we have already partially here at New Jersey Department of Health been working with this case definition for 2017. However, we expect at the local health department level that from here on that they can use this case definition, and we want to fully implement use of these new case or revised case definitions in January of 2018.
Okay, so in a couple months. I have a question here from someone from a local that has their own policy where they make 3 attempts when contacting the provider when it comes to Hep C inquiry reports. They're wondering, should they now follow the guidelines for the 2 attempts for the under 30 over 70 or the 1 attempt with the other groups? What would you say to them?
I would say to them that they should use the recommended attempts that is mentioned in the new guidelines of New Jersey Department of Health. We believe that 2 attempts to the provider is sufficient, and if information cannot be retrieved from the provider, then 2 attempts be made to the patient, and this should be sufficient to, collect the information that's required. Yes, and you always, if it's okay for your office, for your department to do more, that's fine as well. But we are not particularly asking to do more than 2 attempts.
Great. Someone mentioned, what is an RUI that you mentioned?
Oh,
as part of the algorithm?
Yeah, sorry for all our acronyms. Sometimes we assume everybody uses CDRSS, and so they are aware. But RUI simply means report on the investigation.
Great. How about, are there any situations where we would need to update a previously confirmed chronic case?
No. There is, for the most part, I would say no. There is no situations where you need to, although I could think of rare situations where the case was not correctly assigned. That is following the case definition, and in these rare circumstances, then we will reopen the case and reclassify the case. But for the most part, this is not required if the case was correctly classified to begin with.
Okay. And e-closed, someone asked, what does e-closed mean?
It just simply means electronically closed. Again, sorry for all our abbreviations. So this is just a method we use here at NJDOH to help to simplify what the local health departments have to see, and to help to limit the burden on the local health departments.
Great. Well, I think we're going to end here. Thank you everyone for your participation. Just a few other housekeeping tips. Remember, we are offering continuing education credits for those who view the webinar live. You have here some information about how to go about procuring your credits. And then just wanted to do a plug for a future webinar, our 2017 Winter Communicable Disease Forum, which will be in December, and the topics will be Candida auris, hepatitis B, C surveillance. We will be providing you information about a new initiative that we have here, and influenza, and they will also confer credits as well. So thank you very much for spending your time with us, and we hope this has been helpful. Again, this will be posted, as well as the guidance. The guidance is very helpful. All the appendices, all of the tables should be able to really help clarify all the new pieces involved with hepatitis C case investigation. So thank you, everyone, and have a good day.